So let's start our today discussion with this. Firstly, I want to say about what are lungs and what do they do in our body actually, and what happens when we breathe. What are the different types of mechanisms involved? And later on in the upcoming slides, I want to discuss about the respiratory system examination, like how the patient, when if the patient is coming to a doctor with the complaints of hypoxia or dyspnea, what are the main physical examination to be done? These are all we'll be discussing in detail in the next upcoming slides. And moving on to the next slide.
Now, for assessing the lungs, it's critical to understand the normal anatomy of the lungs. So, starting with the lobes, the right side of the lung has three lobes, and the left side only has two lobes. Now, when we're listening to the lungs, we listen in between the ribs. This is called the intercostal space. So, just think in between the ribs, for intercostal is where we listen. Now, the respiratory system sort of looks like an upside down tree. We have the trachea, also called the windpipe, which serves as the stump of the tree, branching off into the bronchus, the right and left. Then to the bronchi, are smaller branches there, and the bronchioles, the very tiny branches, eventually ending at the alveolar sacs, which I call the alveolar apples, because this is where all the action happens. As you know, the alveolar sac is where gas exchange occurs, exchanging CO2, that carbon dioxide, for oxygen. Well, if you don't know, now you know. We breathe out that CO2 and we breathe in that oxygen. Now, it all happens here in the little capillary beds of each alveolus. It's critical to know this when we start breaking down the patho of various diseases. So, if we have fluid in the lungs, like with pulmonary edema, typical for patients in heart failure, where we get heavy fluid all over the body, we get really wet lungs that block this oxygen from getting in. Or if these little alveoli collapse like an atelectasis, well, then gas exchange can't happen and infection settles in, resulting in pneumonia, which we cover in a separate video. So normally we breathe oxygen in and breathe out that CO2, that carbon dioxide, which I call carbon diacid, since too much of it can put your body in acidosis. Now for assessing the lungs.
So right now we have listened about the detailed physiology, what exactly happens when we breathe. And as you can see here, these are the lungs. And we know that the lungs are not the same, like the right lung and the left lung. The right lung is little wider than the left lung, but it is also shorter because it has to make room for the liver, which is right beneath it, and it has three lobes. Whereas in the left lung, it is narrower because it must make room for the heart. So, and it also has two lobes. Generally, in the respiratory tract, it is an extension from mouth or nose to alveoli, and upper airway tract filters the airborne particles and humidifies and warms the inspired air, and whereas lower airway serves for the gaseous exchange in the alveoli, as it is clearly mentioned in the previous video. So this is how the exact circulation happens and how the blood is being filtered in the lungs by the gaseous exchange process in the pulmonary sacs, that is alveoli. Now, further moving on to the next slide, nowadays many clinicians are relying more on the investigation part, like getting ABGs done or X-rays or HRCTs. But examination is much more important than the investigation. Obviously, we do need investigation part to rule out and make the particular diagnosis of a particular pulmonary dysfunction. So, in order to make a proper good diagnosis. But the first and foremost thing is to get a physical examination done. And this mainly includes four: inspection, palpitation, percussion, and auscultation. So inspection is the process uh, where we generally visually observe the general appearance, whether if the breathing smell or whether the body symmetry or not, and the skin color, the movement, etc. Whereas a palpitation is a type of examination where we'll be doing this technique by using hands to feel the temperature, moisture, texture, shape, pulsation, if there is any presence of swelling or lumps in a body and all. And later percussion, it is a technique where we'll be tapping the skin for sound or to locate the particular organs, etc. And auscultation is the main process where stethoscope must be is being used, and stethoscope must be placed directly on the patient's skin. And it is also important to clean the diaphragm or bell of as you can see here, diaphragm or bell of the stethoscope, and it must be clean between the patients to prevent the spread of the infection. And the main process today we are going to discuss is auscultation. Before going to discuss about auscultation, let us understand about the lung sounds. And generally the lung sounds are created by the turbulent airflow throughout the respiratory tract, and it involves mainly two processes: inspiration and expiration. So inspiration is nothing but the way we inhale the gases, and expiration is process of exhaling the gases from the respiratory tract or from our body. So the in inspiration, air moves to the smaller airways hitting the walls, and as the air is been hitting the walls of the respiratory tract, it is more and more turbulent, and increased sound can be heard. And whereas in expiration, as air moves towards the larger airway, less turbulence and decreased sound. So in this process, we can see, like, if you inhale gas, we'll be seeing the more turbulence and more sound, and during the exhalation or expiration, the sound is decreased. So this is how it is been done. And coming to the auscultation process, generally this is a cheap and non-invasive and safe technique, and it is easy to perform. It is one of the oldest diagnostic techniques used by the healthcare professionals, and it also helps in differentiating normal respiratory sounds from the abnormal ones. And this auscultation process is needed to understand the underlying pathophysiology of various lung sounds for the better understanding of the disease processes. And as you can see, this auscultation, it is a process of listening the sounds of air passing through the tracheobronchial tree and alveolar spaces. So if there are any alterations in the airflow or ventilation effort results in the distinctive sounds within the chest that may indicate the pulmonary disease or dysfunction. So before performing auscultation, we must ask the patient to perform full inspirations and expirations through the mouth, so as we can listen to the entire respiratory cycle before moving the stethoscope to the next lung segment. And let us understand what are the different types of locations for the auscultation. Let's go ahead.
Locations. We have anterior, which is the front on the chest, and posterior on the back, where we mostly assess the lower lobes on the back. We want to position the patient upright in high Fowler's position. Point the diaphragm, the big part of the stethoscope, downward, and place it in the intercostal spaces, that part in between the ribs. Now, normal breath sounds are known as normal vesicular breath sounds. are soft and low-pitched
breezy sounds. So these are the sounds which we can hear during the normal functioning of heart, a normal sitting in a normal position if there is absence of any particular disease. So let us understand what are the different types
breathings.
of lung sounds. So let us understand the different types of lung sounds. There are two types of lung sounds: normal lung sounds and abnormal lung sounds. Normal lung sounds can be seen in all the individuals, and this generally includes vesicular, bronchial, or tracheal or bronchovesicular. So vesicular lung sounds are of low pitch, and these are heard over the most of the lung. As you can see, this is the area mentioned here. And whereas bronchial or tracheal, these are the type of lung sounds which are of high pitch, and these are normally heard over trachea, as the name itself says. And bronchovesicular lung sounds, these are the lung sounds of medium pitch, and these are heard over the mainstream of the bronchi. And there are different types of abnormal lung sounds. Let us study them in detail. There are like wheezers, crackles, stridor, bronchi, and pleural friction rub. And I forgot to mention in the previous slide that during the palpitation, percussion, and inspection of the physical examination, these are the three steps. These are the three steps to which are generally performed by the clinicians, and this is where we see like bilateral airway expansion and all. These are the different types of techniques, like techniques of palpitation or percussion. So by these, by we can say the patient is having bilateral airway expansion or not and all, which we can see in the further videos. Let's go ahead with abnormal or adventitious lung sounds and how are they heard, and in what cases they are been occurring, and how it can be treated. Let's move ahead.
First up is the wheezes, which we call the whistle, sounding a lot like this. As you can hear, it's described as a high-pitched musical flute, located throughout the entire lung. But key term here, it's heard mainly on exhalation, or basically breathing out. Now the patho is very simple. Narrowed airways from bronchoconstriction, basically those inflamed lung tissues. And the disease process is typical for asthma attacks as well as COPD exacerbation. Now the treatment for asthma attack, this one is always tested on, so write this down. The memory trick we use is AIM. A for albuterol, this one is given first for brutal asthma attacks. Remember, buterol. It's the one and only rescue drug for asthma attacks. I is for ipratropium, our anticholinergic, to dry out secretions. So just think you can't pee with a tropium, since it dries the body out. And M is for methylprednisolone. Brand name is Celumedrol. Just think it's a slow-acting steroid to
treat the narrow expansion. So wheezes are generally caused because of the passage of air through the narrowed lumen. As we can see, the narrowed lumen in the asthmatic patients and COPD patients, and this is how wheezes these can be heard like a whistling sound. Next, moving on to the further abnormal lung sounds.
Next up is crackles, also called ralls. So just think crackles is for crazy fluid, described as liquidy bubbling or crackling. Now we have two types. Fine crackles is described as high-pitched, like rubbing hair between fingers, sounding like this. And coarse crackles is that low-pitched sound, sounding like Velcro being pulled apart, sort of like this. Now the location of these crackles are typically in the lower lobes, or the base of the lungs, also called basilarity. And the patho is simple. It's basically the alveoli that are popping open from inflammation and congestion. And the disease process is typical for pulmonary edema, that fluid in the lungs, like with patients in heart failure, that CHF, or pneumonia.
And these crackles are the sounds which we can hear in paper crushing the paper. So crackles can be remembered as the paper being crumpled or bubbling sounds. So, and generally these crackles can be seen because of the secretions in the airways, like collections, as it is said here, due to inflammation in the alveoli. It leads to certain secretion of fluids and all, or it might be due to explosive opening of the collapsed area, and it might be due to the presence of pulmonary edema, as it is been explaining right now.
Where we have deep infection inside the lungs. So the treatment, we give diuretics like furosemide for that heart failure patient with pulmonary edema, and for the infection like in pneumonia, we give antibiotics. Next, we have stridor, which we call the serious squeak. This one is a medical emergency because it indicates an airway obstruction, sounding like this. As you can hear, it's described as a high-pitched, harsh, inspiratory whistle. The key term there is inspiratory, when you breathe in. Now, it's located near the throat region during inhalation. And the patho is simple here. Blockage of the larynx, or basically that voice box, or trachea, that windpipe. And it's caused by a choking obstruction, epiglottitis, that inflamed epiglottis, croup, found in kids with a whooping cough, and after a thyroid surgery. This includes thyroid as well as parathyroid. Huge NCLEX tip. I would write that one down. It came up a lot on many different question banks. Now, the key treatment is endotracheal intubation as well as surgery. Next up, we have rhonchi, which we call the rumble, sounding like this. This one's described as a low-pitched rattling or rumbling, kind of like a snoring, located in the bronchi, not the alveoli here. So the patho is mucus secretions or obstruction. The typical diseases that we see this in is bronchitis, COPD, pneumonia, where we have infection, as well as cystic fibrosis, where we get serious mucus in cystic fibrosis. Now, the treatment we use is chest percussion, or basically vibrating the chest with a vest, and fluids to loosen and thin that mucus. Next, we have pleural friction rub, which I call the pebble friction rub, because it sounds like two pebbles being grinded together, sounding a lot like this. As you can hear, it's described as low-pitched, dry rubbing. Again, like two rocks being grinded together. Now, this is located in the front side of the lung during inhalation and exhalation, basically in and out. And the patho is very simple here. Just think of infection causing inflammation in that pleural layer of the lungs, and that is what's rubbing together, causing that grinding sound. Now, the disease to focus on is worsening pneumonia, that infection. So a lot of test questions will ask indication of worsening pneumonia, or signs and symptoms that indicate worsening pneumonia, and the answer usually always includes pleural friction rub. Now, the key treatment is for TCDB, that turn, cough, and deep breathe, to cough out all that infection, as well as use of the IS, incentive spirometer, and antibiotics.
And this pleural rub can be heard because of inflamed pleural rub against each other, and these are generally associated with pleuritic chest pain and lower tenderness. So this is how the abnormal lung sounds.
We
I
start
am
on the
concluding
front,
my
the anterior,
listening.
basically the chest. We want to
Hey,
start at the top
stop.
on the right side above the clavicle, aka above the collarbone. We listen for a full inhalation and a full exhalation. Then we move to the opposite side. Now, we want to compare the quality, the depth, as well as extra sounds. These extra sounds are called adventitious breath sounds. Then we move to the second ICS, mid-clavicular, basically meaning the middle of the clavicle. An ICS is that intercostal space in between the ribs. Then we move over to the opposite side and compare the same thing. The quality, the depth, as well as those extra sounds, those adventitious breath sounds. And then so on and so forth, down to the third intercostal space, compare all the way down to the sixth ICS, mid-axillary. So just think mid-axillary is middle of the armpit. A for axillary, A for armpit. This assesses the lower lobes of the lung, also called the bases of the lungs, or the basilarity portions of the lungs. Now, a little side note here. This is the best place to assess for fluid in the lungs, like with clients in heart failure. So just think HF in heart failure, HF for heavy fluid. And the lung sounds we're listening for is crackles, sounding like Velcro being pulled apart, kind of like this. Pretty crazy, right? So the memory trick we use, think crackles are for crazy fluid. Posterior assessment, in order to get a good clean listen without muffling, have the client lean forward with their hands in their lap to separate the shoulder blades. Start in the same way. Start by listening at the top, then the opposite side to compare, and then down, listen again, over and compare. So on and so forth, working your way down.